Okay, everybody, I think we're going to get started. Good afternoon. My name is Gib Clark. I'm the Program Associate here at the Global Health Initiative at the Woodrow Wilson Center. Thank you so much for coming to today's discussion of alternative health financing in low and middle income countries. Before we get started, I want to tell you a little bit about the Woodrow Wilson Center and a little bit about the Global Health Initiative. The Woodrow Wilson Center was founded by Congress in 1968 as the official living memorial to our nation's 28th president. As he was our only president to have earned a PhD, the Wilson Center attempts to bring the worlds of policy and ideas together. The Global Health Initiative is a newer project at the center, which was founded based on the fact that almost every single program among the 20 programs here at the center were involving health in their work in one way or another. But in addition to serving this clearinghouse role, we attempt to target 4 specific topics: health's impact on development, the role of international and national institutions in global health policy, infectious diseases, and emerging health technologies. For today's event, we are very lucky to have 3 distinguished leaders in international health here today. Speaking first will be Pablo Gottret. He is the lead economist in the Health, Nutrition, and Population Division of the Human Development Network at the World Bank. He oversees the bank's work on health financing and health systems, including public sector financing, Social Security, and public and private insurance. Next will be Marty Makinen, Principal Scientist and Vice President of International Health at Abt Associates. He has more than 25 years of experience in the economics of health, population, and nutrition in low-income countries. He is currently the Director of the Health Systems 2020 Cooperative Agreement and serving on the Independent Review Committee of Gavi. Finally, we will have Hugh Waters, who is a health economist and assistant professor at the Department of International Health at the Johns Hopkins Bloomberg School of Public Health. Dr. Waters' area of expertise include health insurance and health financing reforms, evaluation of the effects of health financing mechanisms on the access, equity, and quality of care, and finally, costing health care initiatives. More complete information on all of our speakers is available in the handout that you could have gotten at the front door. If you didn't, you can get it on your way out. One final note before we start: we are webcasting this event. So when we get to the question and answer period, please wait for a microphone to come around. We'll have a couple microphones circulating, and state your name and affiliation before asking your question so that the people watching at home or in their office or wherever they are can hear you. So thanks again for coming, and Dr. Gottret, please.
Hi, how you doing? Nice to meet you all, and thank you for being here. Only one president of the U.S. had a PhD. I have a PhD. I guess the probabilities of becoming president of the U.S. are pretty low for me. Well, as an economist, they tell us that there is no such a thing as a free lunch. You have a free lunch, and you also have a free book out there, so just pick it up on your way out. We're going to be talking about health financing alternatives, but let me start by mentioning the Millennium Development Goals. You probably are all aware of them. It's the global community made a pledge to the Millennium Development Goals in 1990. Many of these goals are either associated with health outcomes or determinants of health outcomes. We have things such as education, water and sanitation, GDP and GDP per capita, or poverty in general terms, that affect health outcomes. But you have directly reducing child mortality by 2/3 by 2015, and by 3/4 maternal mortality by 2015. And you also have reverting the spread of HIV/AIDS, malaria, and TB. How are we doing with respect to those 2 goals? Well, not very well. On top, you have what we call in the World Bank the regions of the world. We aggregate countries by regions. So the first one, starting from the left, you have East Asia. You have Eastern Europe, Latin America, Middle East and North Africa, South Asia, and Sub-Saharan Africa. What you can see The green horizontal lines are the rate of decrease that you needed in the different MDGs in health if you had started a decline in 1990 in order to reach the goal by 2015. For instance, under 5 mortality, we estimated that you needed a rate of decline on average of about 4.3% per year in under 5 mortality in order to reach the goal by 2015. The bars show what they are actually doing when we evaluating in 2002. And what you can see that in terms of under 5 mortality and maternal mortality, we're doing really bad. But we're really doing very bad, especially in sub-Saharan Africa. In other words, given the trend, we will not reach the MDGs. When you look at the global burden of disease, it's very unequally distributed around the world. 90% of the burden of disease is in low and middle income countries. But when you look at expenditures, those countries only have about 12% of the global expenditure. On the other hand, the higher income countries, which have only about 10% of the burden of disease, have 88% of the global health expenditure. While a high income country spends on average $3,000 per capita per year in health, a low income country spends $30,000. The US spends $6,000 per capita per year. Now, when you look at the burden of disease of low-income countries, and you see a lot of communicable diseases. You see a lot of diseases for which cost-effective interventions exist. Diarrhea, pneumonia, respiratory disease in general. People are dying and kids are dying out of these diseases for which cost-effective interventions do exist. So the question is, why then, if there are interventions, cost-effective interventions for the diseases that are killing a large number of these people, why can't we find the silver bullet that will provide a universal access to a package of essential health services and financial protection against catastrophic spending for this population? Well, there is no such a thing as a silver bullet for several reasons. First, the demographic profiles are very different. Obviously, if you have a high death burden at the beginning of when you have a low income, such as in the case of Sierra Leone, most people are dying before the age of 5. As income grows, populations tend to age and die of other causes. Many of the middle-income countries, this one only shows the huge difference between a high-income country and a low-income country. When you go to the middle-income countries are facing a double burden: high communicable diseases and starting to face non-communicable diseases. And certainly, the financing as well as the health system necessary to tackle these different type of disease profiles and demographic profiles are very different. I don't want you to concentrate too much on this chart, but I want you to notice one thing. In the out-of-pocket expenditure, the 4th column from the left, what you can see is that out-of-pocket expenditures tend to decrease as the level of income of the country, the GDP per capita of the country, starts to increase. When you have very low-income countries, most of the payment for health services is out of pocket. And most of the services provided to this population is by the private sector, not the public sector. That has to do a lot with what you can do in terms of providing services and insurance in these countries to this population. Let me go into health financing now, sources and gaps. When you talk about health financing, you are talking essentially about 3 fundamental functions: revenue collection, pooling, and purchasing. Today we're going to concentrate in these different talks about revenue collection and pooling. Certainly, revenue collection has to be done with, has to be sustainable, has to be efficient, has to be equitable. And in terms of pooling, you also try to aggregate as large pools as possible so that the risk management is efficient, but is also equitable. There are many different models for health insurance, and we will be talking about a few of them. At the highest level, at the highest aggregation level, and people don't think of this as insurance, you have the National Health Service. The National Health Service actually collects revenues from resources from general revenues. It's supposed to be covering the whole population. It is usually pooling at the central government level, and it's usually provided by public sector providers. These are the typical publicly managed systems. We will also talk about social health insurance in a second, community-based insurance, voluntary insurance, and we will not mention out-of-pocket payments except the fact that most people in low-income countries pay out-of-pocket. But when you're talking about the first one, the government intervention, a government running the whole system, collecting the revenues, pooling through the tax system, providing the services, you have to talk about what is called fiscal space. Why couldn't just governments go and aggregate everybody and pay the services for everyone? They have limited fiscal space. Governments can generate revenues for health and in general from the following different sources. Certainly they can try to raise more revenue through taxation. They can also go in debt. The problem in many low-income countries is that they are already indebted. The percentage of debt with respect to GDP can surpass 100%. Moreover, it wouldn't make any sense to borrow money to provide services in health which are largely recurrent in nature. You don't borrow money for recurrent expenditures. So in the case of low-income countries, we are left with two alternatives. One is reallocate resources, become more efficient, prioritize. But when you're spending $30 per capita per year, the gain from efficiency gains is very limited. So largely in low-income countries, they are left with the choice of getting more aid, grants. We will see, and we will come back to grants in the future. Now, remember, we're talking about a public system in this case. Raising revenues. Domestic, as your GDP per capita grows, as your economy grows, you are more efficient in terms of collecting taxes. You can see that high-income countries, for instance, collect tax revenue in the order of 27% of their GDPs. Low-income countries, on the other hand, are on the low side, 14% on average of their own of tax collection over GDP. They can do better, but the increase in revenues coming from taxation is very slow coming. It's very difficult to increase the tax base because you don't want to overtax in terms of the rate of taxation. You want to increase your tax base, and it's very difficult to come, and very slowly. So if we're thinking about the scaling up services for the population as a whole, domestic revenues is not a source of funding that is going to come immediately. Certainly a place where we have to make a lot of effort, but not something that is going to come immediately. When you talk about the public sector systems, you have certain strengths. You know, when you're talking about the law of large numbers and pools, you have a large pool because it's everybody in the tax base and the population as a whole from the expenditure side relies on many different revenue sources, you know, the different types of tax and non-tax revenues, is centralized and therefore maybe it provides at least a common system of governance, but it has a lot of weaknesses. The funding is unstable because it depends on budget. The government may decide, change priority, and cut the budget for health from one day to another. When you look at the expenditure side in low-income countries, it's highly inequitable They usually tend to build the hospitals in the cities where the highest income people live, so they tend to benefit the rich from the benefit perspective, and it's likely to be also very inefficient. There is another type of insurance mechanism, social health insurance. These are systems that are mandated. There's mandated coverage for designated groups. Payment is financed through payroll contributions, usually managed by semi-autonomous institutions, and care can be provided by public or private providers. A lot of strengths, it's semi-autonomous, so independent of budget, so it removes the discussion with the Ministry of Finance every year, generally provides a large coverage of services. The problem is that in low-income countries, you don't have a lot of payroll, huge informal sectors. So, collecting from payroll is kind of very difficult. Coverage in low-income countries is in the order of 15% of the population, if that. As you go to middle-income countries, that tends to increase. But moving and increasing and expanding the coverage without with a huge informal sector is very difficult. So there's a lot of weaknesses. The other weaknesses in many social insurance is the governance issue. Being autonomous from government is okay, but you need a governance structure, and cases of corruption and so on and so forth are not unknown in social health insurance institutions. Finally, another major problem is when they run into deficit, they are powerful lobbyists, and therefore they go and they are able to get subsidies, fiscal subsidies from the government, and eventually that means that the government is subsidizing the better off, those who are employed and have a salary.
Sure.
Community-based health insurance, these are prepayment schemes spreading all over Africa. They are usually the only country that has been able to expand a community-based insurance below, to a large extent that I know is Rwanda. It's covering about 50% of the population right now. But in most countries, it's very small, prepayment of very basic services, community-based, so very difficult to, no prudential requirements, no regulation, so it's very difficult to think that these institutions can be sustained and can be a base for large expansion of financial protection. Voluntary health insurance. Yes, the U.S. essentially has a system of voluntary private insurance. It can be a basis. The problem is that because it's voluntary, it can be only for those who can pay. There's a huge risk selection issue. Risk selection on the basis not only that the insurance companies will be after the people that can pay it, but also the low risks in terms of health. So there is a huge issue both in terms of equity to provide coverage for a universal population. Let's talk now about the alternative for low-income countries of donor aid. We have heard many times, and Jeffrey Sachs is one that goes and says, let's the donors pay the health for the poor countries. It's a minimum amount of their budget. Well, let's see how that happens and whether we're doing a good job. And certainly there is a lot of effort of donor countries to give more money to developing countries, especially low-income countries in Africa, for health. There has been a pledge by donors to give 0.7% of their own gross national income to aid. This chart reflects official donor assistance as a percent of GNI. What we can see in 2005 over there is that the percentage of donor aid with respect to GDP, or GNI, is 0.5% right now, which is way below the 0.7% that has been committed. And the level of donor aid right now, this is not for health, this is in general, the percentage of GNI, of donor aid as a percentage of GNI of the developed countries is only equivalent to that one, to the one that existed, to the ratio of the donor aid with respect to GNI in 1993. So it went down, and it's just starting to pick up. But it's way below right now it's way below 0.3%, not 0.5, way below the committed amount of 0.7% of GNI. The other problem is the composition of donor aid. The white one is the one that we're interested on, because that's donor aid that really goes for projects and programs. The rest is either, the green one is debt forgiveness. You cannot finance health out of debt forgiveness. Okay? Technical assistance, and other things. So the real money that is coming for programs and projects has been declining. It hasn't been increasing. Let's go to the third one. This is not a representative sample, but we studied 14 countries. Out of each dollar that donors provided to these 14 countries, 30 cents never reached the country, never even enters the balance of payments. This is money that is essentially a donor saying in the UK, to pick a country, whatever country, okay? My friend, your name is John Smith. Please do a project for Rwanda out of your desk in the UK. It's money that never reaches the country, 30 cents. Another 20 cents is recorded in the balance of payments, is money that does get to the country, but never reaches the government. So it's a government saying, here's some money, go to Rwanda, go to the health center somewhere, it's an NGO probably, and provide some service. So it's never goes through government channels at all. Another 30 cents reaches the government, reaches the budget, but is earmarked. So it's a donor going to a country saying, Mr. Government, here's some money, but you use it for this particular purpose. And only 20 cents is money that really governments can use for according to their own priorities without being earmarked. However, donor aid for health has been increasing, especially money coming from bilaterals, the UK and some other countries, the US, important increases in donor aid, and some other multilateral institutions, which are essentially the Global Fund, Gavi, institutions that have been created to finance a particular disease or a particular input in many cases. But the private sector, Gates and the Gates Foundation, for instance, is a great contributor to health now. So large increases for health from $6 billion in average 1997-99 to $12 billion in 2003 to $15 billion in 2005. So large increases. A lot of the money is going to sub-Saharan Africa. So is becoming extremely important. Donors are becoming extremely important in the financing of some African countries. In some African countries, not only do they finance 50% of the budget of the government, but they have huge expenditures outside the budget and financing outside the budget. But try to manage this. When we think about health, we're talking about recurrent expenditures, expenditures that have to take place year in, year out. What we see in the behavior of donors at the country level, these are commitments of donors with respect to total health expenditures, is that 1 year they may be committing to finance 80% of expenditures, and the year after that, zero. Now, if you need to hire doctors and nurses, can you do it with 1 year commitments? You can't, because in many places these doctors and nurses are civil servants. So this kind of volatility in donor funding generates a huge problem from governments saying, I don't want to really put money into health systems in order to increase the health systems because I don't have the long-term commitment of the money. The number of donors has blossomed. In the case of Rwanda, where I worked a lot, there is over 100 donors for the health sector. The governments are overwhelmed by just the number of missions from different institutions coming to the country. Okay? And they don't talk to each other in most cases. Okay? They tend to also finance vertically. So they finance HIV/AIDS, they finance malaria, and they tend to fight each other. So the people from HIV/AIDS and the Global Fund and PEPFAR and so on, they hire the best doctors away from the Ministry of Health or away from another one. So there is not only a cost escalation, but a destruction of the permanent health system that exists in the country. So there are huge issues with donor aid. Forget about what this graph is telling you, except for the following. When you look at the impact that money has on outcomes, it's all over the place. You have a paper that I just wrote on the impact of expenditures on outcomes, child mortality, maternal mortality, to be published in Health Economics pretty soon. And the relationship is very small. Why? Not because you cannot be effective with the money, but because when donors come and they are off budget and they go and finance things, and the Minister of Health goes to the Minister of Finance and says, Mr. Minister, I need money for primary care. The Minister of Finance will look at it and says, but donors are there. I'm not going to put my money there. I'm going to take it away and put it elsewhere. So there's a fungibility of donor funding with government expenditures that explains a lot of the lack of impact of money in outcomes. So money is not the only issue. Countries also have, it's not only a donor problem, countries have a lot of issues. Even if you have an impact in the high-income group, you may not have an income in the rural areas, in the low-income countries. So it's also about being able to manage efficiently the money that you have. Let me just conclude. You have to be aware of macroeconomic issues when you're talking about expanding insurance, be at the national level or even with risk-pooling mechanisms such as social insurance. You have to be aware that contributions out of payroll, when they go up, they affect the economy and the competitiveness of the economy. You have to be aware of institutional issues. You have to be aware of the health systems and the things that you do in the health system. Yes, the global community is better if they put their money where their mouth is and they really deliver their commitments, but money alone will not do it. They have to do it in a harmonized and aligned way. They have to finance the health systems of the country and be country-driven instead of trying to lead the changes at the country level. And there is a need for improvement at the country level of the fiduciary, especially the accountability at the country level, the governance at the country level for managing these resources. And the most important thing, we have to monitor and evaluate what we do because we do very little of that. Thank you.
Good afternoon, everybody. My name is Marty Makinen, and I'm from Abt Associates, and I want to give a couple of thanks and disclaimers as I start out. One is that, let me start with some thanks. Thanks to Abt Associates that's employed me for the last 22 years, and to USAID, because most of my employment has been working on USAID contracts and cooperative agreements and given me the opportunity to gain a lot of experience that I'll draw upon in making this presentation. Disclaimer is that I'm not representing either Abt Associates or USAID in making my presentation. I'm representing myself, essentially, at the invitation of the center. So all responsibility for errors or misstatements or plain craziness falls on me. But thanks to those organizations for helping me get to where I can hopefully give you some insights. I'm focusing on health financing in sub-Saharan Africa. I'm going to organize, let's see, let's move. Now I've turned it off somehow.
Make it forward instead of back.
Let's see. What did I do? Obviously, I pushed the
You
wrong
need to
button.
press this one. Let's see.
Okay, there
Just,
we go.
go back and forth. like this.
Okay, great. It's pushing up and down, and it's side to side. So I've organized my presentation as follows. I'm going to provide a little bit of context information about the situation in sub-Saharan Africa and health sectors. Then I'm going to turn to the initiatives that are what many ministries of health would like to go towards, which is social health insurance. I'm then going to touch on the movement towards community-based health financing, which is a live and growing phenomenon in a lot of sub-Saharan Africa. I'm going to mention briefly some other approaches to financing, and then give you some opinions about what the future prospects are, how to go ahead in a positive way to improve the situation, and then draw some final conclusions. And I think you'll hear many echoes of some of the things that Pablo said in his presentation and what I'm going to say, and maybe a little bit of here and there of disagreement on a few things. So watch for those. Situation in sub-Saharan Africa is that it is the lowest income region of the world. However, in the countries in sub-Saharan Africa that haven't been affected by warfare or severe civil disruption in the last 5 to 10 years, there has been growth in per capita income. So there was a little glimmer of the positive on the macroeconomic side for the non-war or disruption-affected countries. Their health indicators generally are quite poor, among the worst in the world, but improving in the countries that are neither affected by war nor severely by the HIV pandemic. And of course, the HIV pandemic, where it's severe, has had drastic impact on health indicators. In terms of health financing, here's an echo of some of the things that Pablo said. There's low health spending by governments. They have low tax revenue, or as Pablo mentioned, small fiscal space. They're only able to capture, according to Pablo's figures, about 16% of GDP in tax revenues. That's much lower than any other region of the world. And then with the revenues that governments have, they make relatively small allocations to health, even though at the Abuja conference of a couple of years ago there was a pledge to allocate 15% of government spending to health. I don't believe any sub-Saharan African country has attained that target, and many are far short of it. So the result is that government spend, by my estimation, this is pretty much consistent with what Pablo and I think Hugh have, about $12 to $15 per capita per year on health, and that donor support adds, by my estimation, about $4 to $5 more. That sounds a little bit high compared to what Pablo and maybe Hugh have, but it's in that order of magnitude. And then private out-of-pocket spending is approximately equivalent to what donors and governments allocate, and I think that's relatively consistent with their data, giving a total of about $30 or $40 per capita available for spending on health. And within that $30 to $40, the spending is very unequally distributed, and unequally distributed in an anti-poverty reduction way, or a pro-rich direction. Richer people dig deeper in their own pockets, and they also find ways to benefit more from both government and donor spending, even though the rhetoric and the programs of governments and donors aim toward the poorest. Somehow the richer tend to capture them. In terms of service delivery, there are two sides to it, government and private side, and governments tend to own and operate their own health centers and hospitals and employ the staff and manage them under a public management type of system that's similar to what Pablo described as a national health system approach, and also is similar to a kind of Soviet approach of central planning to the health sector, where government owns and operates and employs all of the staff. They, by now, in most of sub-Saharan Africa, have achieved relatively wide geographic coverage with their basic health facilities and staffing, but the hospitals that consume a lot of resources tend to be concentrated in larger urban centers. Some of the countries under the, I think it was mid-1980s Bamako initiative, started applying user charges to supplement the government resources that are allocated. And some countries never did that, and some of them have gone back on it and done away with user charges in recent years. Outside of government, private service delivery is growing very rapidly, almost everywhere. And that tends to be concentrated in urban areas, but is also growing fairly rapidly in some rural areas. In Mali in recent years, and Senegal as well, there have been a lot of public sector retirees, people who retire in these countries in their 50s, who go back to their rural areas or rural areas that they've served in the past and start to open up small facilities. A lot of nurses doing those kinds of things. Those, of course, private providers charge user fees for their services. And as Pablo mentioned, a lot of the out-of-pocket spending goes to paying both for services provided by private providers, but also the user charges in the public sector and unofficial user charges in the public sector. And it amounts to about half of total spending. And it's and across the board, rich people and poor people spend a lot out of their own pockets. Okay? Part of the broader context that health financing in sub-Saharan Africa finds itself in is that, of course, the Bamako initiative that I've already mentioned, the growing sector-wide approaches where donors try to harmonize their efforts and work together with governments on their approach to the health sector. The global initiatives that Pablo mentioned, like the Global Fund, Gavi, Roll Back Malaria, and Stop TB, that provide resources but also focus on specific disease problems or inputs like vaccines through Gavi. The Millennium Development Goals have gotten the attention of ministries of health. They're very focused on that they need to be aiming at achieving, especially MDG 4 and 5 on maternal and child health. Poverty reduction strategy papers and poverty reduction strategies that have been promoted by the World Bank also are getting a lot of attention, and at least the rhetoric and strategies state that health programs aim at contributing to reducing poverty. The medium-term expenditure framework tool for trying to align spending with declarations of intent and strategic direction also are finding their way into the health sector, but maybe more used in other sectors. And then there's another external factor is the emergence of new technologies, such as the new, more expensive vaccines that are being created by research and development, the availability of the highly active antiretroviral therapy drugs, and new equipment like scanners and etc. also have an impact on the health sector as populations are aware of these, governments are aware of them, and they need to consider whether to pay for them or not, and how to pay for them. Okay. So with all of that sort of background, let's turn to some of the specific issues. Given that there are both user charges, official, unofficial, in the private sector, and often in the public sector, are there, and that people are required to dig into their pockets to pay for services, those kinds of things are held to, and almost certainly are true, to represent barriers to use of services. And elementary economics would suggest that, of course, any price, and the higher the price, that it has an impact on use of services and a greater impact on those with shallower pockets. The poorer people, when they're faced with prices, will have a harder time being able to pay them and will reduce their consumption of whatever that good or service is. So, of course, the fact that there are charges represents barriers to using services in the first place or using them at an early point in a disease episode or an illness episode so that you can handle that at relatively lower cost and lower impact on your health. Also, when you do have to dig deeply into your pockets to pay for care, it can drive households into poverty that wouldn't otherwise be there. If they face catastrophic payment necessities, they may either have to sell off assets, deplete savings, or borrow, all of which can lead to impoverishment. So then there's a desire for more financial risk sharing. However, financial risk sharing to alleviate barriers and the risk of impoverishment, protect incomes, is very limited in sub-Saharan Africa with a few exceptions. Civil servants, those who work for government, and their dependents often get access to government-provided services at no charge, or they're provided for by a government-organized social insurance scheme. Also, many cases, the formal sector employees are either subject to an obligatory social insurance scheme where there's withholding from their pay and from their employer to fund a pool that pays for their services and for their dependents, or in some cases they're offered private insurance by their employers. However, as Pablo mentioned, in countries like those in sub-Saharan Africa, this population that's covered, civil servants, formal sector employees, and their dependents, usually represents only a small share of the total population, usually less than 15%. And as Pablo also mentioned, there's now developing a movement of voluntary informal sector schemes that I'm going to come back to in a minute. So there's clearly need for financial risk sharing, but the system doesn't achieve very much in that direction. And what it achieves addresses mostly the relatively well-off. Civil servants and formal sector employees are among the richer people in the countries and have less of the disease burden of the type that Pablo described very well in his presentation. So, ministries of health would like to move towards universal social health insurance. They'd like to jump right to that solution to the problem of providing broad-based financial risk sharing. In countries like Kenya, Uganda, Nigeria, and Senegal that I visited just last week all have on their list of intentions and in their strategies to try to develop universal social health insurance. However, the conditions, macroeconomic conditions, again echoing what Pablo said, don't make that very feasible or maybe feasible at all in the short term or even medium term. There's a very low share of the population in the formal sector, so those from whom you can collect social insurance contributions at the source, very limited. And tax collection more broadly is very difficult, as we saw from the limited fiscal space. So the plain feasibility of very wide coverage through a social health insurance program remains something that's somewhat distant. And then in a recent paper by Adam Wagstaff from the World Bank, he's made the argument that social health insurance is not much better than general revenue financing anyway. So you can take a look at that if you wish. Now, in parallel with the desire of ministries of health to move rapidly to universal social health insurance, which is probably not very realistic, there's also been a growing and spontaneous development, largely spontaneous development of community-based health financing, especially in West and Central Africa. And that's where rural and urban communities and professional groups have spontaneously begun creating voluntary self-managed schemes. Okay? and that have all the weaknesses that Pablo mentioned in his presentation. But they do come from the grassroots. They are at least have proved a certain degree of feasibility, and we'll come to some country examples in just a minute. In East Africa, the growth of these kinds of schemes has been positive, but not at the fairly explosive rates that we've seen in West and Central Africa. The schemes in East Africa tend to be facility-based rather than coming out of the community or out of professional groups. And it's not quite clear yet why that's the case, but it seems to be a difference that is linked to slower growth. So let me just briefly give you 4 country cases in great summary and not in great detail on the development of community-based schemes. Tanzania, the first one on my slide here, has a centrally designed community scheme, which is a little bit of an oxymoron, but it's named a community scheme, a community health fund, but it was designed centrally. And it includes a central co-financing of the premiums that are paid by those who join. However, it's achieved a very low share of the population. It's a national scheme, less than 5% covered. And it appears that one of the reasons for low uptake of the scheme is that the user charges that are made at public facilities are fairly low and are fairly affordable, so that there's not a strong motivation to join. In Ghana, my second case, Ghana experienced the relatively fast growth in numbers of schemes and growing membership in schemes from the late 1990s into the early part of the 2000s that were then taken over, in a sense, by a national health insurance act that called for obligatory community health financing schemes, that receives also an explicit tax subsidy, taking 2.5% of sales tax and a bit of the formal sector pension contributions. And it's achieved about a 20% coverage by last year. And colleague Yogesh Rashkotia from USAID has gathered a lot of data about this. However, this scheme exempts from payment those under the age of 18, which is probably close to the majority of the population, and those over the age of 70. And it turns out that about half or more of those who have joined are in those categories that are exempt from payment, and the centrally assigned premium rates don't match up with the costs of the benefits package that was also centrally developed. So this doesn't look like it is sustainable as a scheme, and lots of people who can get into it and not pay in are the ones who are the first to join, which makes sense from their point of view, but may not give the results that are sought. In Senegal, there has been this spontaneous growth of numbers of schemes, and this little graphic here shows how the number of schemes grew from 1997 to 2004 at a very rapid clip. In Senegal, the government has taken a relatively light touch to working with the schemes in terms of developing an overall framework to support and promote the schemes, consider some relatively light regulation of the schemes rather than taking them over or imposing a central design on them. They still have only achieved about 5 to 10% of their population covered by these, and there's still a lot of fragility to the schemes themselves because of lack of management skills and some design issues with the schemes that have a multiplicity of designs, since they're all spontaneously developed. And then lastly, there's the big success story of Rwanda, which follows a model of a joint facility and community management of the schemes in partnership. So it's neither facility only nor community only, but working together. But I think one critical factor there is local government active promotion of membership in the schemes. The National Ministry of Local Government has made it a criterion of performance for the mayors of the local communities that they encourage scheme membership. And they have achieved 70% coverage. I just got recent information from Francois Diop, who was in Rwanda a couple of weeks ago, that they've even exceeded the 50% that Pablo mentioned and are up to 70%. So they're really the outlier and maybe a place that some lessons should be drawn for elsewhere. So it shows that at least some scalability exists to these kinds of schemes. So that's community-based health financing. And now briefly to some other approaches and challenges. One is that where there are user charges in place, that targeted subsidies or exemptions from payment are a possibility for alleviating the barrier effect and maybe even alleviating some of the income protection problems as well. There is the possibility of targeting the poorest through exemptions and subsidies that would be in alignment with the overall poverty reduction strategies and permit the poorest who have the biggest burden of disease to have access to these services. There are also subsidies that can be targeted to specific services, like preventive services, to target groups of people, the children under 5 and pregnant women, specific services like deliveries and chronic care, in order to achieve more in a public health sense by alleviating the barriers, the financial barriers to those specific services. And I just completed an assignment in Senegal, where it looks like there are some very interesting prospects for making progress in that direction. Then there are initiatives that have mostly had experience outside of sub-Saharan Africa, but in similar conditions with performance-based financing, so setting some performance criteria for providers to meet and giving them financial rewards. Haiti and Afghanistan and Rwanda seem to have had some positive experiences with those, but they're relatively new and could be ways to get some greater efficiencies out of the use of the resources that are there. And then there are initiatives with contracting between the central level and districts, or contracting with NGOs to deliver services as well. There also has been a surge in the use and the performance and the use of national health accounts and sub-accounts analyses that can help the health system and health system leaders to identify misallocations, inefficiencies in the use of the limited resources that are there. But a big question about that is about national health accounts is, will there be both the political will and the ability to address the misallocations that are identified? Just is not yet clear. There's also a big challenge in those countries that are benefiting, thankfully, from PEPFAR and the Global Fund for the support of antiretroviral therapy, because that is, unfortunately, even with the drop in the antiretroviral drug prices, still an expensive proposition, and one that has to be carried out for a long time for any individual, and that there are successive waves of newly infected people coming into the system, which means that the cost burden of antiretroviral therapy will grow and grow and grow over time until transmission can really be interrupted or reduced. And there's some question as to the sustainability of the levels of support that's being received from external sources now, but even more so when we can see that the total cost of those programs, at least for the foreseeable future, will continue to grow at a fairly rapid rate. And then finally, with the new vaccines, new drugs, and new technologies, I mentioned the vaccines and technologies before, the new ACT combination therapies for malaria are much more expensive. How do you decide which ones to bring in, which ones to accommodate in a system that already has trouble paying for the basics? Okay, so with all of that, both a somewhat positive and somewhat bleak situation, some future prospects. In terms of community-based health financing, I think that thanks for that, recommending a light touch approach to promoting the development of community-based financing, to certainly try involving local governments in the process, not leave it to be a health sector only initiative, to try to learn and build upon the what's happened in Rwanda, and to integrate community-based health financing with other initiatives such as decentralization that gives more resources and more power to local authorities, and to broader poverty alleviation initiatives such that, as is being thought about and proposed in Senegal, targeting health subsidies using general poverty reduction funds that have been set aside. Okay. Also, as whether or not community-based health financing solves a lot of problems for a lot of people, it has a side benefit of teaching people about financial risk sharing, which is an otherwise very remote concept, and prepares them, especially the rural and informal sector people, for the day when you might it might be feasible to apply a social health insurance model or some other kind of global model. Okay? And then with the existing social insurance for the formal sector, many of those systems have a lot of sustainability problems of their own. They have efficiency problems in their relationship between the payer and the provider of services, and getting those things straightened out in the near term will also provide a sounder foundation for their expansion over the longer term. Then, since the private sector in terms of provision is rapidly growing and very important as a source of care, it's important for ministries of health and governments in general to take into account and recognize the size and importance of private service delivery, which they do to only a limited extent now, and involve thinking about the private service delivery as important potential actors and real actors in their financing and their financing-related initiatives, something that's rarely done now. I think it's worthwhile to think about making the subsidy regimes, the sets of subsidies that I mentioned before, more effective and more efficient. You could probably achieve a lot of improvement in access to health services, short of waiting for the day when you can do universal health insurance, by straightening those out and making them effective. And then institutionalize the performance of national health accounts analyses and in the use of data. And then finally, join fully the health sector into poverty reduction efforts by targeting subsidies and then being able to make claims on some of the resources that are available for poverty reduction more generally. So my conclusions are, and here I echo Pablo again, there's no single magic bullet for health financing in sub-Saharan Africa. I'm glad that you used that phrase first. But there are some good possibilities to do more and better with the current financing through community-based health financing, improved subsidy policies, using national health accounts results to change allocations, to experiment with performance-based financing, and to take greater advantage of what's going on in with private service delivery. And finally, I think there are more resources that can be had for the health sector from government budgets generally. I think that governments could allocate more. They said they could when they made the Abuja Declaration, and to tap into some of the broader poverty reduction initiatives for the benefit of the health sector. And with that, I'll thank you.
Okay, well, thank you very much for your attention and your patience. And I'm going to turn my attention to Latin America. I'm going to echo many of the thoughts that both Pablo and Marty have put forward. I'll try to do it relatively quickly so we can leave some time for discussion. First of all, there are some connections among us. You may have guessed that. It's a pretty small world, the world of health financing. I'm on the faculty in the Department of International Health at Johns Hopkins School of Public Health. We are one of several organizations that are part of the consortium Health Systems 2020, which is financed by USAID, is headed by Abt, and Marty is the director of that project. I've done also a fair amount of work over the last few years with the World Bank, including with Pablo's unit. I've had a chance to work throughout North Africa and in Latin America as well. So we do know each other. We do talk, and that's why one of the reasons you'll see a lot of similarities in our presentations in terms of vocabulary and thoughts. I want to very quickly put in a pitch for the book that Pablo is discussed and is distributing. Is called Health Financing Revisited. I teach a class at Hopkins on comparative health systems and health financing, and we use that book. So there you go. There's a strong endorsement for it. It's got the most up-to-date, most kind of crisp analysis of health financing challenges internationally that I think you're likely to find right now. Let me go ahead and jump into the presentation. We're also working on a book, by the way, right now, which is a little bit short of seeing the light of day right now, but it's going to be on health systems coverage, so shifting from financing to insurance and looking at more middle-income countries rather than low-income countries. So again, with Pablo's help and the World Bank production staff, we're hoping to produce that book within a few months' time. Okay, let me talk to you a little bit about Latin America. These numbers are going to be fairly familiar at this point because both Pablo and Marty have talked quite a bit about things like GDP per capita, life expectancy. These countries, these regions of the world vary dramatically in terms of GDP per capita. This is just a level of income. The world is $9,000. Sub-Saharan Africa is about $2,000, and Latin America is about $8,000. Remember, this is overall economy. This is the amount of money that the countries have in their total economy, and this is adjusted for purchasing power parity, so it's already taking into account cost of living differences. If it was unadjusted, it would show much smaller numbers for both Sub-Saharan Africa and Latin America. When you turn to health, health financing is extremely inequitable, as both Marty and Pablo pointed out. Sub-Saharan Africa, $36 overall, $588 is the world average. The region I'm talking about, Latin America, is a little bit higher than the other developing regions, $222. And that's one of the themes that I want to discuss in my presentation here, is that Latin America actually is at another phase in the transition of health financing and health coverage, perhaps introducing different issues than those that are currently the most important in Sub-Saharan Africa. The issues in Latin America, I'm going to put forth as a hypothesis for you, have to do with coverage, how to use your health financing system to cover people effectively. And so I'm going to suggest that those two things, coverage and financing, are intricately linked, and then try to see how the two can be dealt with together in a systematic way. So here's some characteristics of the region. Spending about 7% of the economy on health, $222 per capita. One of the interesting things about this region is the extreme variations in coverage. The main mode of coverage in the region in terms of healthcare is through social security institutions. This would correspond to what both Pablo and Marty discussed as social health insurance. So it's covering employees in the formal sector of the economy. In most countries, it covers their families as well, but not in all, as I'll point out in a second. So it is not an ideal source of coverage for a low-income country, for reasons that have been stated. Among other things, it's regressive. You're covering people that are in the formal sector. You're covering the best off people in your country and in your economy. However, it is the predominant source of coverage in Latin America, with a lot of variation in terms of coverage rates. So that's why it says here insurance for elite groups in general. That's not always the case. And even though it's a transitioning region, there are still big problems with communicable diseases. So a lot of the problems that Marty talked about in Sub-Saharan Africa have not been completely bypassed, particularly in the poorer parts of the continent. In the Andean region in particular, communicable diseases remain a real problem. So I want to talk about three countries very briefly. Again, trying to be cognizant of the time. I want to talk about Mexico, Ecuador, and Costa Rica, partly because these three countries all illustrate very different points about what's happening in the region. So let me do that, and I just have 2 or 3 slides on each country. Again, what I'm going to do, rather than try to be comprehensive in terms of what's going on in these countries, I'm just going to present a couple of points that I think are salient for this discussion. So in Mexico, some very interesting changes are happening in a couple different ways. One is the relationship between Social Security Institute and the Ministry of Health. In Mexico, and another is increasing coverage to basic services, particularly in rural areas. So Mexico demonstrates very well this sort of tension between Social Security coverage and Ministry of Health coverage. So about half of the population in Mexico has access to the Mexican Social Security Institute, the formal health sector, the formal Social Security insurance, which also covers health. The rest of the population, in principle, has access to the Ministry of Health services. But as in many Latin American countries, that access is less than ideal. In many cases, in some rural areas, it's non-existent. So even though the population in principle has access to Ministry of Health services, it's less than fully satisfactory. So what the Ministry of Health is trying to do in Mexico, as I'll show here in a second, is try to introduce a basic package of services to cover those rural areas. In Ecuador, there are similar issues, but Ecuador is further behind Mexico and is basically just trying to get formal sector insurance up to a certain level, and at the same time try to cover the same rural populations that currently lack access to health care services. Okay, so, and I may actually, depending on how the time goes here, may actually skip Costa Rica because it's even a further advanced country in terms of the evolution of the insurance and the financing. So let me just go quickly into Mexico. Julio Frank, who was a candidate for the DG for WHO this past go-around, and up until very recently was the Minister of Health in Mexico, is sort of the brainchild of the what's called the Seguro Popular, which is the rural health insurance program in Mexico. Here's some indicators for the country. A very large population. It's a middle-income country in the parlance of the World Bank and others, with a per capita income of about $10,000, and about $500 of that being spent on health care. So the challenges are that public health spending is very low, so that's typical of Latin American countries, even though there is a Social Security system differentially benefiting urban and employed populations. Overall, health spending is really low from the public sector. Okay, so about half of the population is without health insurance coverage, and when that half of the population has very sporadic access in terms of Ministry of Health services, and in some cases, not at all. Out-of-pocket spending, which has been a sort of a theme already today, discussed quite a bit, it's a really important indicator because it shows you just the extent to which people have problems of access to health care. If over half of your money in the health sector is coming from out-of-pocket payments, you can pretty much be guaranteed that you're going to have some serious problems in terms of inequity of access. When that much money is being paid out of pocket, it means that the poor are going to be very much disadvantaged. So that's a big problem in Mexico. And then you can see some of the inequities in terms of the regional distribution of health spending. So what is the Mexican government trying to do? A couple of really interesting reforms, and one which is not the subject of my discussion today is it has to do with taking oil funds and linking it to conditional cash payments, conditional cash transfers they're called, to encourage rural and poor families to do two things: keep their kids in school and use basic health services. That's called the Oportunidades program. It's a conditional cash transfer program. It's gotten a lot of interesting play. That's actually not what I'm talking about here. I'm actually focusing on something called the Seguro Popular, which is a rural people's insurance, a rural health insurance program. The idea is quite simply, you've got a large segment of your population without access to even basic services. So let's give them a package of services, not necessarily expensive, but at least covering essential primary and basic curative healthcare services. So that's the emphasis right now in Mexico. The money is coming from federal government, from state government, and a small premium for those that can afford to pay it. And the public sector remains the provider of choice here, but the idea is that you're injecting new funds into the health system through this health insurance program, which is covering the poor with basic services. Similar programs, by the way, have been implemented in Bolivia, a maternal child health care program, and in Ecuador as well, which I'm about to talk about here in a second. Okay, so apologies for the speed with which I'm going. I probably would, if I was teaching this class at Hopkins, I'd probably take like an hour to discuss this stuff. But because of all the students would be asking lots of impertinent questions, I appreciate your patience and letting me talk as long as I have. Let me talk about Ecuador. So this is something that's really close to my heart. I spent a large part of the last year and a half working in Ecuador. I've led this project, which is funded through World Bank assistance, to work directly with the government to achieve some basic goals of health reform. We had a really unique opportunity in that after quite a bit of political upheaval, we had a president in Ecuador who had been a minister of health, and who was actually the intellectual father of the health reform program. That's very unusual to have that kind of political support. I'm not sure that we got as far as we would have liked to under President Palacio, but we did make quite a few strides. So here's some, this, by the way, is if for those of you who are interested, this is every dot here is a country. I don't want to overwhelm you with this, but every little dot is a country. This ranks countries by their wealth, and this ranks countries by their health expenditures. So you can see a few things right off the bat. As you get richer, you spend a lot more money. No extra credit for figuring out which country that one is. But here's Ecuador, way down here. So, and a lot of Latin American countries are right down here, spending just $100 per person per year. So your basic challenge in a country like Ecuador is how do you spend those $100? And you already know that the Social Security system is spending part of those $100, and it's spending it on the wrong population from the public health standpoint. It's spending it on the urban employed population. So, and out of pocket, 60%. That's a huge, huge issue, as I said earlier. And here's where the money comes from, over half coming from households, then a variety of public sources. The Social Security Institute is down here, Ministry of Health is here. Anyway, that's a real mix of financing in terms of the current situation. What I just want to quickly walk you through is what we've proposed to the government and what they actually are implementing, although not as quickly as we would like. This is the Social Security distribution. So as I said, this is the overall population. I apologize, this is in Spanish, but it gives you a good idea. Here's the age groups. The distribution of the overall population is in blue. Distribution of those covered by Social Security is in red. Ecuador is unique, or almost unique, in Latin America in that the Social Security insurance, what we've been calling social insurance, only covers the worker. It doesn't cover the worker's family. So that's point number one. Not only is social insurance regressive, but when you only cover the worker, it's a little bit worse if you don't cover their family. So our proposal to the Ecuadorian government is as follows. Here's the current situation. Okay? Out of 13 million people, about 70% have no insurance. About 3% have private insurance. 9% are in the Social Security Institute. Armed Forces. This is a rural health insurance program. Okay? So we're proposing to first expand coverage. We have proposed, and the government is actually, this has already been passed. The law has already been passed. It's in the process of being implemented. Expand Social Security coverage, the Ecuadorian Social Security Institute, to cover the family of the worker. That's point number one. That gets you to, increases the coverage of Social Security to 17% and lowers the no insurance to 62%. We have recommended, and then again, this is something the government has taken initiative on, a rural health insurance program, very similar to what we've seen in Mexico, the one I just described in Mexico. This program, although it's destined to be a rural program, is starting in the cities because that's where they are most able to implement it. So they're covering poor people and now in Quito and Guayaquil and Cuenca with a basic package of services. Once they get to the whole population, which is going to be a long time, that will cover 35% of the population. That's the poorest 35%. And that would reduce the no insurance to 33%. And then eventually, and I'm not even going to suggest when this might happen, Social Security would be extended to the rest of the informal sector, and you would get eventually to close to 100% coverage. So that's an idea for how a country like Ecuador, with a currently regressive insurance system, health financing issues, could eventually get around those issues. And they're starting to do that in a piecemeal way, in a very exciting way, by covering populations in the peripheries of the big cities and cover the dependence of the Social Security insurance, et cetera. So I'm going to actually pass on Costa Rica. The interesting thing about Costa Rica is that Costa Rica has achieved 90% insurance coverage through a Social Security system. A very fascinating case study for those that are interested. Costa Rica is a country that doesn't have a professional army and has invested instead very heavily into health and education sectors, but 90% coverage through the Social Security Institute. So you have different models in Latin America. You can go with your rural health insurance program with services provided by the Ministry of Health, or you can try to combine into one system both the Social Security and Ministry of Health, which is what has been the alternative in Costa Rica. So in the interest of time, let me pass on to the next step.
Okay, thank you all very much for excellent presentations. We have 2 microphones, so if you have questions, raise your hand and we'll get one of them to you as quickly as we can. Let's take John and then pass it back 2 people, please.
I'm John Sewell. I'm a senior scholar at the Woodrow Wilson Center. These were very lucid presentations, so thank you. I've got 2 sets of questions. One is the politics of healthcare reform. I mean, most healthcare systems that I'm vaguely aware of obviously give first payoff to political constituencies, whether it's measured economically or however it's measured. And has the emergence or the reemergence of democracy in Latin America made any difference for the political pressure, i.e., do you have to have a more equitable healthcare system if you want to stay in office? The second is, and this is a particularly, but I think probably not exclusively African question, is what's the capacity to deliver? You alluded to the fact that PEPFAR and the Global Fund are siphoning off the talent and attention and so on and so forth. Even if you solve the financing problem, is there the capacity to deliver good health care in the way that you're all 3 of you are talking about? And if not, how do you get it?
Yeah, please.
Hi, my name is Kazumi Inden. I'm MBA student at GW. First of all, thank you very much for very insightful presentations for all the speakers. My question is particularly for Dr. Gottret. What positions the World Bank takes, or what recommendation the World Bank provides?
Describe this other one coming around. Sorry about that.
Excuse me. So what the positions the World Bank takes, or what recommendation the World Bank did to country offices or other donors in terms of bridge the current volatility and insufficient of financial resources and long-term objectives in this transitional period? Because I believe that if we fail to retain, especially the human resources in the low and medium income countries, it might prolong the long-term objective. Thank you.
Let's take those 2 questions, then get a couple more.
Okay. Well, I can try the first one.
Okay.
All right. I'll tackle the first one since it talked a little bit about Latin America. The issue of political stability. Well, first of all, I couldn't agree more that the health reform and politics are intimately linked. I've worked now in enough places and had enough frustrations to know that you can have a beautifully designed plan and it doesn't go anywhere if the stars are not aligned politically. So in Latin America, the political trends are super interesting to me. I mean, they're in the Andean region. There's a trend, politically speaking, I guess it's to the left. In viewing it from the health sector perspective, it's more in terms of emphasis on rural populations and covering poor populations. It's sort of a populist approach, I guess. And that, to me, that works extremely well in a country like Venezuela or even in Mexico, where there are sources of funds to do that. It doesn't work as well in a country where that money doesn't exist. So if you're talking about, so I think it's a very positive trend when oil monies and external sources are being used to cover poor rural population. In a country where that money doesn't exist, Bolivia comes to mind, which has some external resources but very few. Ecuador has also limited external resources. I think it puts a real stretch on government budgets. And it's a very complex question, obviously, politically, but it's an ambiguous situation in terms of whether it's going to end up being a positive or not positive outcome.
Let me address that question a little bit, even though it wasn't asked about specifically about Africa. But I was in Senegal last week. Senegal had its presidential elections on Sunday, so politics was very much at the forefront of everybody's minds and activities last week. All of the candidates for president, there were 14 of them, they all had platforms that talked about health in one way or another, so they at least included health in their platform. A lot of them had what those of us who have equity in mind in the health sector had proposals that seemed kind of primitive in that their proposals were build more hospitals everywhere and not very realistic. However, they're also in some of the discussions that we had within the ministry about their subsidy programs, we noted that their overall strategic declarations for the health sector and their poverty reduction strategy included citizen accountability as a theme, and that we didn't see that in any of the subsidy initiatives that they had, and that we proposed that we might make some suggestions to them about those kinds of things. They were very receptive to that idea, and I think that was related to the highly political atmosphere around multi-party, multi-candidate elections, that they want to get the citizenry involved in the health sector, and they see that as an important way of engaging politically. So I thought that was quite interesting, because when we raised it, we kind of, my colleague and I, when we raised it, we were a little bit apprehensive that they might just say, no, we don't want to have anything to do with that. That's for others to take care of and keep it out of the health sector. But we got the opposite reaction. Then on the question of capacity to deliver, there are real questions about the capacity to deliver. There's a big out-migration of health workers to the richer countries, from English-speaking countries to the U.S. and the U.K. and Canada, from the French-speaking countries towards France and elsewhere. That's reducing the capacity to deliver. There's also the skewing of resources towards well-funded programs like the ones that provide antiretroviral therapy and away from the primary care. However, there is a capacity to deliver if the resources were there for primary care services, the ones that would address the biggest share of that burden of disease. And even without strong measures to stem the migration problem, you'd still have the capacity to deliver a lot more that would address a bigger share of the burden of disease, although it is worth worrying about capacity in a broader sense.
Just 2 questions. I was thinking about not mentioning this, but I will anyway. Talking about Bolivia, I'm from Bolivia, and the politics, I think it's really interesting. Definitely, without political commitment, you cannot give your reform. I'm not going to say whether it's good or bad, but I'm just going to give you an example of how politics plays into this. For many, many years in Bolivia, we had been trying to increase the number of people, medical doctors working in the rural areas. It was very difficult. It had to be negotiated with the medical unions, had to be negotiated with the medical unions who didn't want to move to the rural areas. So the stone block was essentially medical protocols, right? So the medical doctors would negotiate a medical protocol that would essentially, the health services provided in very rural areas would be essentially very, very basic. I'm going to just give not a real example, but essentially if you get a cut in the rural area, you get a Band-Aid. If the cut is infected, you have to be referred to the rural to the city. I mean, it's just an example. It's not a true case, but essentially protocols were very restrictive of services in the rural area. And when you wanted to negotiate, it was very difficult to negotiate with unions. When the new president came back, the second story is that a lot of the studies would say, there is difficult to have people in the rural areas come to this health services. It has to do with culture. It has to do with a lot of things. Well, anyway, to make a long story short, when we have a new president from the rural areas, he comes and says, I'm going to bring Cuban doctors to provide services in the rural areas. So the medical union says, no way, we have the protocols. I don't care about the protocols, I'm going to change them. The protocols get changed, and the doctors protest, but he changed them anyway. Now the Cuban doctors are in the rural areas. Utilization of services has increased dramatically, no cultural issues. And when the rural doctors complain, says, well, I also have Cuban doctors to go to the hospitals. Do you want to continue on the strike? So the problem was solved. I don't know whether it's good or bad, but it's just an illustration of how politics does play a role in health. Regarding the World Bank and the recommendations to donors to bridge the gap in financing, especially in human resources, the human resource issue is very complicated. We just said it's very political. But it has to do also with the capacity of governments to sustain a level of effort for a long period of time with the issue of fiscal space. The bank doesn't have a position. What we are trying to do is trying to help the governments make sure that when they want to take an action, they are able to finance it in a sustainable manner, try to work with donors to provide funding if they want to do it through government, do it provide the funding in a long term, durable financing for predictable and for a long term. And thirdly, we also try to look at alternatives, like in the case of Rwanda. Rwanda is a really good example where the doctors are not civil servants. Or if they are, only a limited number of civil servants are provided to the health centers. And the health centers are able to hire additional doctors and nurses with their own resources, or with that they may raise locally or through the local governments. Moreover, they're able to provide top-ups in terms of performance-based. The health center gets a performance bonus from either governments or what has government have agreed with donors from donors. So donors, when they come to finance a particular service or a particular initiative such as HIV/AIDS, they are able to underwrite contracts with the health centers. Now, those health centers are receiving funding from elsewhere. It is supervised by the community, and they are able to contract doctors, even civil they don't have to be civil service, although the facility is a public sector facility, and therefore are able to attract doctors to go to the rural areas. So there are initiatives out there to manage the human resource issue, and that's what we have to study and just disseminate good practices from all over the world in order to manage this issue.
And make one more comment that comes to mind that's a little bit astray from the health sector, but I think is very, very interesting thing that I observed last week in Dakar, is that throughout the city there were billboards and posters for all the candidates, and most of them were just their photo with their overall slogan. But some of them were related to issues, and a subset of them. One that I saw only one example of was from the incumbent president, Abdoulaye Wade. And that was, during my term of office, girls' education has increased by 29%. I said, wow, that kind of a social issue is seen, at least by the incumbent president, as one that will attract votes. Whether or not he actually did it or not, I think that's an example of where a democratic process is raising the profile of social issues, even if it's not health specific.
Okay, let's take right up here, Liz.
My name is Elizabeth Schenecker, and I'm in the Office of Population and Reproductive Health at USAID. I hope you won't gasp at the naivete of my question, but I've always wondered about this, and Dr. Gottret's comments gave me the courage to ask, so let me ask. In the U.S., we pretty much assume that most of the population will get its health care in the private sector, and that the public sector acts pretty much just as a safety net for those who can't get their care in the private sector, and the public sector also is regulatory. But when we provide assistance in the developing world, we almost always do it the other way around. We focus on building up the public sector and providing assistance to the public sector so that it would be the provider of most public services to most people. And the private sector functions pretty much just as a, well, this is, broad brush, but pretty much as a small sector that serves an elite. So I'm wondering why we do that, why we do it that way instead of the other way around. And connected to that, I'm wondering, is there any merit in kind of delinking, when you're talking about services for the poor, delinking the financing from the service? In other words, could the government do the financing of services for the poor, but through the public sector?
And then just pass the microphone along.
Thanks for some very, very interesting presentations. My question is regarding sort of the preconditions for any of these financial mechanisms. I had the chance in the last last year, I guess, to visit a bunch of countries, Ethiopia, Yemen, Senegal, Georgia, and others, and they're all very much interested in developing social health insurance systems, sometimes tax-based insurance systems, or even strengthening their subsidy schemes. But in many cases, I wonder if some of these countries are ready for it. A good example is Ghana that you brought up. You mentioned that there was a 20% 20% coverage, but in fact, only 8% of the ID cards have been distributed because they can't print the cards. They can't figure out how to connect the individual with the ID with the printer. And so there's a lot of sort of preconditions that I'm wondering about. So what advice would you give to governments who are interested in developing these financial either risk pooling mechanisms or subsidy mechanisms, who are gung-ho about doing it, but may not meet the preconditions that are necessary?
Okay, and let's just pass it forward one, and then answer those three.
Karen Kavanaugh from USAID. First of all, thanks to all the presenters for excellent, thought-provoking presentations. I guess because I work for a donor organization, one of the questions that comes to mind in this policy context is not whether a particular financing instrument is a good one or a better one than another one, or stronger or weaker, but rather, should a donor invest its health money on helping countries straighten out financing versus other alternative uses of that same funding? Because another way of using our donor funding is to go directly to the interventions that Pablo showed in his chart, which is to fund technical assistance, to fund commodities, and to ensure that they're delivered to the site. So could you speak to any of the evidence about because I guess the rationale for working on financing as a donor is that it improves coverage and utilization of services that have health impact. So could you speak to evidence that you are familiar with about the rationale for investing donor resources in financing, what the evidence shows about increases in coverage?
That's great.
Sure, that's great.
Go ahead.
Do you want me to tackle the last one? Which is, I think both the question of separation financing and provision and financing are really, really interesting. I don't think that there is any reason why government should deliver services if they can buy it. I mean, there is no precondition there's nothing that can illustrate that government can do it better than the private sector necessarily. So both require different kind of skills. I think purchasing services is perfectly valid. It's being illustrated all over the world, and it can do it. But it does take a government to regulate as well and to contract. And there's other kinds of skills that are required for that purpose. But certainly it can be done, and it has been done all over the place. Regarding financing rather than going directly, the problem, and this is from my biased perspective, and you can read my paper if you believe my numbers, donor of funding off budget will not produce outcomes, period, because they are not sustained and because there is no additionality. Governments will just move their money away for other purposes, so the money that you put in there is not additional money, it's just fungibility takes place. Moreover, it gets worse. Let me give you a sequence of events. A donor comes and funds off budget. The Minister of Health goes to the Minister of Primary Care. We want less kids to die, we want less mothers to die, let's finance off-budget donor funding through an NGO directly somewhere. Minister of Health goes to the Minister of Finance and says, Minister, I want more money for primary care. The Minister says, well, the donors are funding that, I will take it away from you, not primary care. Maybe I put some money in hospitals, but mostly it will go to defense. Then, next step, we saw the volatility of donors. Donors are there 1 year and not the next. Okay, the donors pull away, go away, and now there is no funding in that place for primary care. The Minister of Health comes to the Minister of Finance and says, my donors are gone. I don't have the money. It's not being serviced. Do you think by any chance that there is any possibility of that Minister of Finance now taking the money away from defense or even from hospitals and putting it back to primary care? No. You can see also the results in the book. There is, we did a quantitative analysis of the possibility of doing that. End result, less primary care once the donors left than when they never came. So there is no way that donors can sustainably fund their own priorities in a country. The priorities of the country and the donors have to be aligned. And in order for that financing to be sustainable, they have to work together in a plan that they agree. Now, in the case of U.S., they cannot fund budgets in countries for regulations that exist in the U.S. They usually fund off-budget. Okay, they go and finance off-budget. Off-budget doesn't mean that it has to be off-plan. You know, they could do the off-budgeting financing, but they should agree with the government and the other donors on the plan that they will finance for the health sector so that there is no duplication and that there is alignment of interests and efforts.
Okay. Let me take a little bit of a cut at each of these. The question about the delinking of financing from provision and more participation by private providers. And I think that I agree with the question that was asked, or the suggestion embodied in that question. And that was part of the point that I tried to make by saying include private provision in health financing initiatives so that they don't aim just at the government side, but even set up a possibility for both to compete with each other within the initiatives. In terms of preconditions for interventions in the Ghana case of 8% ID cards, et cetera, in many cases to create the preconditions, you need to start small and not try to swallow going to universal coverage all in one go. We see in Rwanda that's achieved on its community-based health financing this dramatic scale-up. That came from doing some careful piloting and working out of procedures over a several-year period of time. There's a sort of an aversion to pilots because there's a notion that they never get scaled up. Well, Rwanda's a case where they do. Ghana's a case of which there are many where you try to go to scale without testing out how you can do it, what are all of the not only conceptual issues, but also just the nuts and bolts issues of making things happen. So I'd suggest that we need to carefully assess where to do pilots or smaller scale things before going to scale as one way forward on that. And then on the question about whether donors ought to invest in financing or alternatives, I think my answer is it's not one or the other, but you need to do some of both in tandem, because there are lots of inefficiencies and ways that the financing initiatives can make the programmatic initiatives achieve what their potential is, that they reach a certain limit and can't go any farther. And we've done some research under the PHR Plus contract with USAID on the impact of community-based health financing coverage on use of USAID's defined priority services, and didn't see a complete impact on all of the services, but significant impacts on the use of some key services through community-based health financing coverage. So that's an indication that that's one way that some of the kinds of programs that have start to bump up against ceilings can find a way to move farther and increase their coverage through financing initiatives. Let's see. I guess I'll leave that there.
Okay. Should I go ahead and respond? There's a comment in the back. All right. I'm going to go ahead and just give my response to those questions, which are great questions. Thank you very much for the provocative questions. So the general question about the public and private roles, that's a fascinating question. I would really like to separate in responding to that the public-private role in financing from the public-private role in delivery. In most low and middle income countries, the private role in financing and coverage is really, really small, and it's going to remain really, really small. I mean, conveniently, there's Ecuador with 3% private insurance coverage. It's not going to get above 5 anytime soon, and that's the case in most countries. I mean, internationally, including high-income countries, private insurance counts about 5% of total global health expenditures. So, should we be promoting private insurance? I would argue probably not in a lower middle-income setting. Should we be promoting private provision? That's it's up for debate, I would say. Is the private sector better at producing services than the public sector? Probably. Is it more efficient? Probably. Is it going to provide the services that poor populations need? Probably not. And how would you get the private sector to do that? There's some interesting experiments going on, contracting in Cambodia and Afghanistan, others. I would say it's far too early to make any conclusions about the private sector being able to provide services on a cost-effective basis for poor populations. Granted, there's a lot of inefficiencies with government provision, but I think there's some things that governments have to do. And providing healthcare, basic healthcare to poor populations, I would put forth as one of the things that governments have to do. I'm trying to be a little bit provocative. On the issue of donor financing, I'm very, very concerned, I'll try to be provocative on this one too, that donors are taking too much of a role in financing. We talked earlier about recurrent costs. It was I haven't been in this field too long, but I do remember 10, 15 years ago, it was sort of anathema that governments would get involved in finance recurrent costs. Now governments are financing soup to nuts in terms of vaccine programs, the whole cold chain, the vaccines themselves. Those are recurrent costs. When it comes to things like antiretroviral drugs and the systems that support them, it's more than just an academic question. I mean, what's going to happen when the donor financing stops? And so while I think there's a very, very, very strong argument for donors investing in those services, I would think that we all, in our various capacities, should be thinking about what the future is, and are the governments going to have the capacities in place to continue to providing, in this case, the drugs and the expertise that goes with it. So I'll just, having been provocative, I'll just leave it at that.
I think we only have time for one more question back there in the back here.
Hello, my name is Jose Sumar. I'm from Macroeconomic Consultants. I'm an economic and information consultant. I just arrived to the United States. I lived in Peru for many years. I know that ABT has some operation in Peru. And of course, Mr. Pablo Gottret is from Bolivia, very close to Peru. Many of the concepts that you talked about apply to Peru. And many of the problems you mentioned also apply to Peru. That when you have donations to Peru, really don't get to the people. They don't arrive to the people. You know, they get lost in the way. There's a lot of corruption, and the social security system. Nobody wants to go there. You know, it's like justice and health in Peru is things that nobody wants to go through. What's your point of view, specifically of Peru, regarding health, above many of the concepts you already explained that already apply to Peru?
Well, I used to live in Peru, but it's been quite a long time, and I'm not actually currently working there, and I'm not aware of the current politics. So I'm actually going to pass on that question, and my colleagues probably would feel the same way. I think I don't know that we know enough of what's going on there right now. Thank you for the question, though.
Well, one related point about Peru. I'm not going to directly answer the question because I don't have the current familiarity, but it relates back to the question about democracy. Is that in a couple of local government units, the project that under the PHR Plus project from USAID, our colleagues working in Peru supported popular referendums on health priorities at the local level, where the technicians made some nominations of these are possible priorities for us to invest in and work on in the coming few years, and then put them up to a popular vote. And so the people were able to express what they thought were the more important problems to work on. And then presumably, when the next election comes, if they haven't, those local health authorities have not responded to those kinds of things, they can be held to account. So that's an interesting intersection of democracy kinds of initiatives with accountability in the health sector. Our colleagues there also, in the run-up to national elections, hosted what they called health policy breakfasts, where they invited political parties to send representatives to breakfast meetings where they're giving briefings on health issues and encouraged to present their parties' platforms or to discuss ideas. So that was a way that USAID, through that our colleagues' work, helped to bring more democratic debate about health policy at both a local and national level. But whether those are effective or not remains to be seen.
Let me mention a couple of things. I don't know to what extent they are Peru-specific, although I know that a similar program is in place. But there are a few countries like Bolivia. I know that Peru initiated this some time ago, and Argentina is another case, where there is transfers, block transfers from the central government to the local governments for specific health purposes. And the purchase of these services can be done both of the public and the private sector. The maternal child programs are coming to mind. I think it's a very interesting example. The results are very positive in the case of Argentina and Bolivia. It gives the government, the central government, when it has a priority, the possibility of transferring resources with a very specific purpose in mind, and even make it the block grant condition on the actual output that it generates. In the case of Argentina, for instance, you purchase maternal health services if you give an additional bonus or whatever, or performance-based bonus, based on the targeting of those services to the poorer populations. So I mean that